Welcome back to Child Mental Health for Pediatric Clinicians, helping you help kids. I'm your host, Dr. Elise Fallucco, child psychiatrist and mom. It is a great honor and a joy to be able to continue talking with Dr. Jeffrey Strawn, child psychiatrist extraordinaire, professor of psychiatry at the University of Cincinnati College of Medicine, and co-author of the new book, Stahl's Deeper's Guide, which is an incredibly user-friendly manual to help us figure out the best ways to take patients off of various psychotropic medications and or switch them from one medication to the other. And today we're continuing our conversation about SSRI medication. We're going to talk about the most popular and famous SSRIs, Fluoxetine, Sertraline, and Citalopram or Citalopram, but also talk about in which cases we would use FluVOXamine or Luvox. We'll talk about when Dr. Strawn recommends switching to an SNRI as opposed to an SSRI, and the latest science and clinical applications about varying metabolism of medications through the cytochrome system, the 2D6s, the 2C19s, and what that means for us as we're prescribing and deprescribing meds. But most importantly, while this is a lot of advanced technical talk, we wanted to ground it in a discussion of real clinical cases. Without further ado, let's continue our conversation with Dr. Jeffrey. So let's go back to another fun clinical example to test our knowledge.
Let's do it.
The patient who failed sertraline 150 got switched to fluoxetine, titrated up to, let's say, 30 or 40, now has failed that trial of a second SSRI. So the question is, do you switch the patient to a third SSRI, or do you move to an SNRI for their anxiety?
So this is for anxiety. So I would probably still try another SSRI. There's probably some caveats there, some asterisks that I would add. One is that if there are a lot of physical symptoms, I might move towards something like a Duloxetine. Let's say they'd had a high dose of sertraline in an earlier trial and not had any tolerability concerns and not had any benefit. I probably wouldn't go to escitalopram or citalopram just because I'm thinking, is there a possibility that that patient may be an ultra-rapid metabolizer in terms of 2C19? So maybe I'm not going to another 2C19 metabolized medication. But I love this example of fluoxetine because I think this is one of the few medications that we've actually studied in child psychiatry in terms of relapse prevention studies, those older studies by Graham Emsley and colleagues, and Taryn Mays and others. But it's also one where its kinetics make things a little bit more challenging or actually maybe a little bit easier depending. So let's take a second and maybe unpack that. So in the case of fluoxetine, as we know, we can certainly discontinue that relatively rapidly. And if we look at the pediatric studies that have stopped it, they've generally, from doses of 40 milligrams, decreased to 20 milligrams per week and then stopped it. I think that is certainly very, very reasonable.
And just as a quick reminder, because fluoxetine has such a long half-life, the medication almost self-tapers. And so you can go from 40 to 20 for about a week before stopping.
Absolutely. Now, the other issue where this becomes a little bit more important is if I'm going to a medication, even in something that's not an antidepressant, that is metabolized via 2D6. Remember, fluoxetine and norfluoxetine are pretty significant inhibitors of 2D6. And so that effect will persist over that time period when the medication is self-tapering. So I'll still have Prozac-related 2D6 inhibition over those 4 or 5 weeks after I've stopped the medication. And that may have some implications in terms of what's going on with the new medication that I'm starting.
I just want to highlight what you just said because it's an incredible clinical pearl. What you're reminding our listeners is that even after stopping fluoxetine, it'll still be in your system for another 4 to 5 weeks, which means that the related cytochrome 2D6 inhibition will also be in effect for that long. So practically speaking, this means that if you start a new medication that's metabolized by 2D6 after stopping fluoxetine, a low dose of the new medication is going to feel more like a medium or even high dose due to the ongoing 2D6 inhibition as fluoxetine is leaving your system.
Exactly.
And for those of our listeners who might need a quick refresh on which of our commonly used antidepressants are metabolized by 2D6, just a reminder, this would be the SNRI, Venlafaxine, marketed as Effexor, and Duloxetine, marketed as Cymbalta, as well as an SSRI that we don't commonly use, Paroxetine or Paxil. So I want to go back to a couple things. One is that in most cases, if somebody's tried 2 SSRIs for anxiety, your preference would be to try a third SSRI as opposed to switching to an SNRI. First, I want to say I agree, and I'm glad to hear that, that you're...
It's so nice when 2 psychiatrists agree, isn't it?
And while I always give patients the opportunity and talk about the different options, my personal clinical experience has been, and also based on research, it seems like the SSRIs tend to be more effective and to have fewer side effect burden than the SNRI options in our teens and children. Is that why you do it, or what's your rationale?
It's exactly the same. I think when we're talking about efficacy, and we look at several of the meta-analyses that have been published in this area in pediatric anxiety, the SSRIs really win the race. From a tolerability standpoint, I think the SNRIs are pretty heterogeneous. So we have some SNRIs like Venlafaxine that are just notoriously not well tolerated. And I think the issue there is that, I tend not to use Venlafaxine if I can ever avoid it. And so in that situation, when we're just saying SNRIs, we're grouping a lot of things together. So for me, when I'm thinking SNRIs in child psychiatry, there's probably only one that I might use for anxiety, and that would really be Duloxetine.
Yes, I completely agree with that. Yeah, and I'm throwing around the category like we have so much from which to choose, so many SNRIs, and I really just meant Duloxetine.
Right.
But back to the case of somebody's on fluoxetine 40, you're saying we could easily decrease to 20 for a week and then off. What would be your third SSRI that you would choose?
So this is a situation, depending on what's there, I might go to Luvox or FluVOXamine. I think a lot of people forget about FluVOXamine, and it can be a really effective SSRI, both for OCD, where it's approved in the pediatric population, but also for run-of-the-mill generalized separation and social anxiety disorders.
I love hearing that because I think a lot of people have steered away from that medication and kind of focus more on the big 3, fluoxetine, sertraline, and escitalopram. And maybe citalopram has a little bit of a role there, but either one. And while we've moved away from paroxetine, I think people also have slowly moved away from FluVOXamine or Luvox. But I'm interested to hear that would be your third one. And before you had said some of your rationale might be, let's say they've tried a high dose of sertraline, which is metabolized by 2C19, and there wasn't a really good effect, then it makes you think that maybe they're an ultra rapid metabolizer, that we might run into the same problem with citalopram and escitalopram. Is that why you wouldn't choose those, or is there a different reason?
That's precisely it. And maybe put that another way, if I have a patient that had very, very significant side effects at a low dose of sertraline that I was pretty convinced were related to sertraline, I might not go with escitalopram or citalopram as my next line intervention, because there's a possibility that patient may be a poor metabolizer for 2C19. Obviously, these are labs that we could check if we wanted to, but here I think we're trying to really use the clinical evidence and make our best guess in terms of inferring.
I like how you're organizing those 3 meds together, citalopram, escitalopram, and sertraline, because of the way they're metabolized, and also informed by a lot of the pharmacogenomic studies that you guys have led, looking at the wide range of variability found in how quickly people metabolize those particular meds based on their own 2C19 polymorphisms. Okay, so if they were fluoxetine 40, you would decrease the 40 to 20 milligrams while starting Luvox at that point, or would you wait for the Prozac to get out of the system before starting Luvox?
In this situation, I think it would be, depending on timing and other practical issues, I would probably start the Luvox the day that the fluoxetine stopped. I would probably start at 25 milligrams. I know that there are some that do start at 50 milligrams. I tend to, just because these are still different SSRIs, still titrate, as opposed to just starting at, say my goal dose, which would be around 150 to 200 milligrams. I would never start at that dose. The other thing that I think is really interesting, when we look at how fluvoxamine is dosed across these individual pediatric studies that we have, if we look at things like the POTS study, again, this is OCD, they titrated this fairly aggressively. And similarly, we can look at the adult COVID studies where they titrated this incredibly quickly, much faster than I would ever do, essentially getting to a couple hundred milligrams of fluvoxamine over several days. I would not recommend that. The other thing is that when we look at the pediatric OCD study, the POTS study, what we do find is that there was a higher incidence of side effects in that study. And I have certainly wondered if that was probably related to the rate at which it was titrated.
That maybe it was aggressively titrated, and so they ended up on a higher dose perhaps than they needed, which increased the side effect burden.
Mm-hmm.
Okay. Oh my goodness. I could talk to you about clinical cases all day, but I need to let you go and see patients.
This is fun. This is great.
Well, sadly, I have to say goodbye to you and we have to end our conversation. As I mentioned before, I'm going to keep a link to your book on our website, Psych4Peds. I highly recommend it to our listeners. I think it's fantastic how you organize it by medication name and medication type. And so you can literally use it as a reference and flip to, bupropion or atomoxetine or whatever it is. And there's a very systematic way of going through what should you look for as you're coming off of this med, how to approach it, and even things like what dose should you decrease it to and over how many weeks. So it is a fantastic reference. It's available on Amazon and highly recommended. And as a final thanks, I just want to say thank you so much, Dr. Strawn, for being able to translate all of your wisdom, not only into this book, but into clinical discussions to be able to help other pediatric clinicians.
Thank you so much for those kind words. And it's great, as always, to continue that work here on your podcast.
Oh, thank you. That's the goal. All right, listeners, we covered a lot today, but I wanted to have a chance to do a broad recap. Some of the highlights from our conversation. We talked about when you've got a child or a teenager with anxiety who has not responded or failed trials of 2 different SSRIs. Dr. Strawn recommended switching to a third SSRI typically, and the rationale for that being that the SSRIs tend to be more effective than the SNRIs and also typically with fewer side effects. When we were talking about which SSRI to choose with a patient who's not responded to fluoxetine or sertraline, Dr. Strawn surprised me by saying that he would seriously consider FluVOXamine or Luvox in that case. And as a side note, I keep thinking about how we actually don't talk about this medication and perhaps don't use it very often, which reminded me in my weird train of thought about that movie Encanto and the song We Don't Talk About Bruno. We don't talk about Luvox. Anyway, back to the recap. Dr. Strawn mentioned that he really likes Luvox not only for OCD, but for our big 3 anxiety disorders: generalized anxiety, social anxiety, and separation anxiety. He talked about starting at 25 milligrams and then titrating up to a target dose of around 150 to 200 milligrams. Another big clinical pearl from today's episode was the idea that you can mentally organize 3 of the SSRIs in a similar category based on their metabolism. So in this case, we're talking about the 3 SSRIs that are all metabolized by 2C19. So that would be sertraline or Zoloft, S-citalopram or Lexapro, and citalopram or Celexa. So Dr. Strawn mentioned that if your patient developed pretty bad side effects on a fairly low dose, then that might be a clue that they're a really poor metabolizer through 2C19. So you'd want to avoid other meds that are in the 2C19 class. Another big clinical pearl, while we all know that fluoxetine or Prozac tends to have a really long half-life, and so does its active metabolite, norfluoxetine, Dr. Strawn reminded us that even after stopping fluoxetine, that you're going to have the fluoxetine-related 2D6 inhibition for an additional 4 to 5 weeks after stopping the med. So something to keep in mind if you've got a patient who you're starting on another 2D6 med, like Duloxetine or Venlafaxine, or potentially Paroxetine, although we don't use that one that much. Whew, lots of information. And it may be really hard to remember all of this technical information about dosing strategies as you come off of meds or as you come onto meds. I do want to strongly recommend Stahl's DePrescriber's Guide, available on Amazon, co-authored by Dr. Jeffrey Strawn, as a helpful reference tool so that you can just alphabetically flip to whichever medication that you're planning on switching from or switching to, and you'll be able to find really helpful dosing tables and information about, when would you decrease the dose, by how much, for how long, and then at what point would you start the next med. All right. That brings us to the end of this episode. Thank you so much for listening. And as always, please check out our website, psyched4peds.com, and sign up to become a friend and colleague of the podcast so that you can get our regular free newsletter with recaps from episodes, helpful downloadable resources, and other tools. Until next time, take care.